Good evening. My name is Jackie Hislop, Principal Clinical Researcher at Canon Medical Systems. And on behalf of Canon, it's my great pleasure to welcome you to the fourth day of our MSK series. Last evening, we discussed imaging pain in MSK-related conditions through a spectacular array of images and case studies, and we follow that up today with our presentation on MSK-related oncology. Now back to this evening, it gives me great pleasure to introduce our moderator, Professor Cronkey. Professor Cronkey is the newly established chair of the Diagnostic and Interventional Radiology at the Medical Faculty of the University of Augspur. So, as you can imagine, we are exceptionally happy to have him here as a moderator, guide us through the presentation. Professor Cronkey, the session is yours.
Thank you, Jackie, and a warm welcome also from my side to this day 4 of the MSK days. The topic for this evening is oncology, as you have noted, and it's my great pleasure that we have two distinguished experts in the field of diagnostic and of therapeutic options for oncology in bone tumors. The first speaker will be Professor Alain Blum. Professor Alain Blum is currently the chief of MSK Emergency and Neck Radiology departments at Central Hospital, University Hospital Center of Nancy. He's an expert in the field of MSK diagnosis of bone tumors, and I think we will not only learn more about imaging and the use of high resolution imaging, especially for tumor characterization, but also how these tools then later on can be used for treatment and for guiding treatment. So, Professor Blum, it's my great pleasure, and the floor is yours.
Thank you for this nice introduction. Hello, everybody. I'm very happy to participate to the Canon MSK Days dedicated to oncology and to share this session with Thomas Kröntke and Julien Garnon. My presentation is dedicated to the role of new CT tools in the detection and characterization of bone tumors. How do they help us in daily practice? Guidelines usually recommend the use of multiple techniques to improve our diagnostic efficiency, and that is what we do in our institution. This is of importance as the decision that will be made largely depends on our findings. Depending on the cases, we can be the only ones to guide care or participate in decision making with multidisciplinary team meetings. In all cases, CT plays a major role in decision support, but also to guide the biopsy or thermal ablation. CT plays a major role for the diagnosis of bone tumors. It can show a lytic or sclerotic appearance of the tumor, a cartilaginous matrix, a periosteal reaction, and many other characteristic features. However, this technique still suffers from some limitations, and I would like to show you how some additional tools can overcome some of these limitations and push the boundaries of imaging. Some of these techniques are recent, others are already tested and have been the subject of multiple publications, but they are not yet distributed by all manufacturers. These tools can be divided on the one hand into acquisition and reconstruction techniques, and on the other hand into post-processing techniques. Of course, these different tools can be combined. The first technique I would like to show you is the bone subtraction technique made possible by a specific algorithm that subtracts bone structures but not their vascularization. This algorithm is different from the one that erases all the bone structure and calcifications that we use to analyze the vessels. This case is our very first case of bone subtraction applied to the study of the bone in 2009. It is a case of an osteoblastoma with a very calcified nidus which was unidentified on previous CT and MRI. Bone subtraction allows us to identify the intense tumor vascularization. The principle is to subtract the images without injection from the injected images to better visualize the contrast enhancement. Of course, we can combine subtraction with perfusion imaging, which includes several acquisitions at the same anatomical level, and it is thus possible to collect an enhancement curve of a sclerotic tumor. Here, this curve shows us an early and intense enhancement followed by a washout. Why should we evaluate bone tumors and bone marrow with perfusion imaging? To increase the conspicuity of the lesions, to assess the tumor activity and treatment response, and I will just show you some different examples. There are many applications, both diagnostic and therapeutic. Here, for example, it is a case of a young patient who presents an osteosteoma in the weight-bearing zone of the medial condyle near the subchondral plate. The perfusion CT scan shows the intense and early enhancement characteristic of a nidus. Given the risks to cartilage and subchondral bone, the energy delivered during laser therapy was half the usual dose, with nevertheless a destruction of the nidus, as we can see on the bone subtracted image on the right. With a follow-up of 2 years, there is no recurrence or mechanical complication. This is a case of a 47-year-old patient who presented with a lytic metastasis of C-set vertebra. CT with subtraction shows intense enhancement of tumor tissue. The proposed treatment in a multidisciplinary team meeting was thermoablation combined with vertebroplasty, and you can see that the perfusion scan with bone subtraction shows the disappearance of the tumor enhancement after the thermoablation, which very likely indicates satisfactory destruction of the tumor tissue. The open rib is the second technique I want to show you. This is an automatic process that has 3 main steps: segmentation, labeling, and unfolding. Results that look like a flat fish bone are automatically sent to the PACS. In this case, while conventional analysis takes a long time, the open rib shows us in a single glance the metastasis, the insufficiency fracture of the right 7th rib, and the constitutional synostosis of the 3rd and 4th left ribs. So we save some time. What do you think of the case of this young pregnant woman who is referred to us for a suspicion of chest wall sarcoma? Well, the CT scan clearly shows us an extensive lesion elongated along the long axis of the rib, slightly expansile, with well-defined margins and a thin sclerotic rim, thinning of the cortical bone, and endosteal scalloping, and in places a ground glass appearance. It is therefore easy to reach a diagnosis of fibrous dysplasia. The advantage of open rib in this case is to provide an overview of the rib in one piece, facilitating the analysis. This is a case of a patient who presented with a lytic lesion of the humerus with medullary infiltration discovered incidentally on X-rays of the shoulder and on MRI. We immediately performed a CT scan of the shoulder and the chest. The classic analysis did not show any other lesion, whereas the open rib revealed some lytic punched out lesions of the ribs, allowing us to make the diagnosis of multiple myeloma, and retrospectively, rib lesions were found on axial CT images. CT with metal artifact reduction is a useful tool in the evaluation of bone tumors, or more precisely in the search for tumor recurrence after surgery for bone tumor. In general, in the case of bone sarcoma, surgery involves reconstruction with significant hardware. An ideal tool for the follow-up of this patient would be efficient despite the huge amount of metal to diagnose local recurrence as well as implant complications such as sepsis or loosening. CT scan with metal artifact reduction includes pre and post contrast acquisitions. It is not a perfect tool, but in our experience, it is an effective tool. Moreover, it can be combined with the detection of distant metastases. It is well tolerated by the patients, and this is of importance to avoid loss to follow-up patients. Currently, our follow-up strategy is based on a regular CT scan every 3 to 6 months, depending upon the risk factors of recurrences, and we found this strategy cost-effective. This is a case of a patient with local recurrence 2 years after treatment of a chondrosarcoma. He was lost to follow-up during 1 year, and CT scan without MAR hardly shows the local mass, whereas with metal artifact reduction, the local recurrence is really obvious. Of course, when the lesion is large, all imaging techniques are efficient, but therapeutic options are very restricted. The objective is to detect small local recurrence, like in this case of a 58-year-old woman with chronic alcoholism and bone infarcts. She was operated for an indifferentiated pleomorphic sarcoma, and CT scan after contrast medium injection and using metal artifact reduction clearly shows a small local recurrence. Last case I'm going to show you, this is a case of a 77-year-old man operated for a chondrosarcoma with the local recurrence, which is well depicted with CT scan with metal artifact reduction. Ultra high resolution CT is probably the most innovative technique, the one that will perhaps change the semiology of bone lesions because it allows us to visualize things that were not visible in vivo until now. For example, this technique offers an unparalleled view of bone vascularization with a probable impact on the diagnosis of lesions and also on the prognostic analysis of osteosarcoma or bone healing. This technology is mainly based on a new system of smaller detectors and the use of deep learning reconstruction algorithms. The result is an unrivaled spatial resolution close to that of the micro CT, along with an excellent signal-to-noise ratio. And in a few years, all CT machines will offer this spatial resolution with the popularization of photon-counting CT. This is a case of a young man with a giant cell tumor of the radius compromising the integrity of the subchondral plate. The question is it safe to perform curettage, or should the patient receive treatment with denosumab prior to surgery? After performing ultra-high resolution CT, the multidisciplinary team meeting decision based on the visualization of a persistent rim of bone was no denosumab prior to surgery, and the results of the surgery were satisfactory. I would like to show you this case of a conventional osteosarcoma because it shows that ultra-high resolution CT improves the analysis of bone lesions with here a clearly visible cortical invasion by the tumor. Why should we study the matrix of bone tumors? To better characterize the lesion, to improve the correlation with histopathological findings, to evaluate treatment-related changes, and to detect complications such as fracture or malignant transformation of benign lesions. This is a case of typical fibrous dysplasia of the left fibula in a 72-year-old man with polyostotic fibrous dysplasia. In fact, on X-rays as well as on classic CT scan, we can see here a ground glass appearance. But ground glass appearance is a radiological finding, not an histopathological description. Indeed, the aspect of a fibrous dysplasia can actually be quite complex, and ultra-high resolution CT reveals several patterns which are close to the histopathological description and which are quite specific, with here a gritty psammomatous pattern, bizarrely shaped immature, non-stress-oriented disconnected trabeculae coexisting with fibrous tissue. In fact, the ground glass appearance is just due to a lack of spatial resolution. Why should we evaluate the vascularity of bone tumors? To better characterize the lesion, to assess tumor activity, to develop new biomarkers of angiogenesis, and to guide treatment. You probably have in mind these two articles published in 2011 which show that a dilated vascular channel or even several can be observed in contact with an osteoidosteoma in the cortical bone. The interest of these works is to remind the hypervascularized nature of this tumor, but also to note that bone vascular analysis can be a diagnostic aid. In fact, the structure and function of blood vessels within the bone have long been of interest, but they were hardly perceptible with standard imaging techniques. Now look at this osteoidosteoma with a clearly visible vascular channel on a CT scan with classic spatial resolution. You have a close-up on the right. Now look at what we get with an ultra-high resolution CT. We cannot even count the number of transcortical vessels that we can see. You may have thought that all these black dots were due to the noise, but these mini images clearly show you that there is a connected network of perforating and transcortical vessels which merge more or less towards the nidus, taking the appearance of a Medusa's head. It is even possible with global illumination rendering to depict the periosteal reaction and the many vessels perforating the periosteum, and also to segment the nidus and its main vessels within the cortex. You therefore understand that this technique opens a road for the evaluation of bone vascularization, which could not be assessed until now with any other imaging techniques. Here is a case of a skull vault tumor discovered by chance on a head CT. MRI shows a highly vascularized intradiploic tumor with a spoke wheel pattern and no fat tissue. Ultra high resolution CT shows a typical hemangioma. It shows an intradiploic, lytic and expansive lesion with a spoke wheel pattern due to thickened trabeculae. And perfusion ultra high resolution CT shows a rapid and marked enhancement of the lesion with dilated arteries merging to the lesions and multiple dilated veins leaving the lesion. So to conclude, I hope I have convinced you of the interest of these different CT techniques for the diagnosis and the evaluation of bone tumors. Ultra high resolution CT is truly a breakthrough for bone analysis, especially for exploring cortical vessels. And finally, you will no longer speak of the vessel sign, and you will refer to the Medusa's sign for osteoid-osteoma. Thank you very much.
Thank you, Professor Blum, for this really outstanding presentation. I think we will have the Q&A at the end, so please note your questions. We will also keep track of what is posted in the Q&A. And it's my great pleasure now to introduce Professor Julien Garnon. We will now switch gears and go to treatment of bone tumors and understand how imaging can play a role in planning and guiding the treatment of bone tumors. Professor Garnon is a professor of interventional radiology and practicing at the University Hospital of Strasbourg. He is a very expert in cryotherapy of musculoskeletal disease, but also other tumors. And his presentation title is Embolization, Ablation, and Consolidation of Bone Tumors. Julien, we are keen to see what you will present. Thank you.
Thank you very much, Professor Kranke, It's a great pleasure for me to be part of this webinar today. So thanks a lot to Canon for the kind invitation, and good evening, everyone. So we just have seen with Professor Bloom that radiology for diagnostic is an outstanding tool for bone tumors. And also it gave you a glimpse of how we can also try to fix a problem. So nowadays we are not only looking at the problem, you can also try to see it. So during the next 20 minutes, I will try to show you what are the tools in our armamentarium and when we try to use it to optimize the outcome for the patient. So let's have a look at the different treatments that we can propose for bone tumors. I will start with embolization. The principle of embolization, I'm pretty sure that you know it already. It's quite simple. The goal when you have a tumor, which usually is an hypervascular tumor, you're going to catheterize the different feeders. Usually there are different ones, not only a single artery, and then through your catheter or microcatheter deliver the embolic agent, which most of the time for tumors, or at least bone tumors, is most likely to be particles. Of course, you can use also other agents such as liquid agents and coils, but the basis for treatment are particles. And the goal is to devascularize the tumor using this treatment. So what are the indications for embolization? If you are looking at the literature, and you probably know it in your clinical experience, one of the indications of embolization is the adjuvant preoperative therapy. So when a patient is referred for surgery, mostly resection or surgical consolidation, such as nailing, for example, if the patient suffers from a hypervascular cancer, thyroid, renal cancer are the typical example, or HCC, for example, hepatocellular carcinoma, then usually we have to go for embolization prior to surgery to decrease the blood loss during the surgical intervention. And as shown in this paper, one of the most important things is to reduce as much as possible the time between embolization and surgery. You can see here that if you operate on the patient a day after embolization, then this is the time where you get less blood loss compared to a delayed embolization. So that's a typical indication for embolization. And here is an example of femoral metastasis from renal cell carcinoma. You can really see the hypervascularization from the tumor, feeders coming from different arteries arising from the superficial femoral arteries, which were catheterized and embolized. So we embolized with particles and then coils. You can see the coils here in the different feeders. And I think what is interesting is just to show you the follow-up. So that was the surgery which was done immediately after. So the patient was put under general anesthesia. We did the embolization, and right away in the surgical room, he had undergone intramedullary nailing. What you have to know is that embolization is not really going to control the tumor, because I'm going to show you the X-ray 6 months after, and as you can see, the tumor has grown. So when we do embolization, when we perform embolization, we have to keep that in mind, that we're not going to ablate the tumor. We're going to decrease the vascularization, most likely to reduce the growth of the tumor over time, but we're not going to ablate it completely. That is to keep in mind when you have to treat patients with bone tumor. So another indication, potential indication of embolization is the palliation of painful bone metastasis, ideally from hypervascular cancer. So same example that I have just talked about, HCC, RCC, renal cell carcinoma, or thyroid cancer. And as you can see in this review article focusing on spine tumor ablation, you can induce quite long-lasting pain relief, several months following your embolization, despite the fact that it's not going to completely control the tumor. You can control the symptoms for a period of time, which is quite reasonable in a palliative setting. Now, you may be aware that chemoembolization is used a lot for the treatment of intrahepatic hepatocellular carcinoma. Some authors have proposed to use this technique to treat bone metastasis from HCC. This is a paper from Japan showing that chemoembolization for patients who failed first-line radiation therapy, or at least who recurred after first-line radiation therapy, may benefit from such a treatment for pain palliation. So really the goal is not to destroy completely the tumor, but to decrease the symptoms of the patients. So this is reported in the literature, but I'm just going to show you that maybe today we have better tools than embolization to achieve long-lasting pain palliation. Nevertheless, when we talk about percutaneous treatment, embolization may have a major role as a pre-ablative treatment. What I mean by that is that you may want to reduce the vascularization of the tumor prior to ablation, and I'm going to detail ablation right now. And the goal is to reduce the so-called sink effect. So if you see that renal cell cancer, which is highly vascularized on CT scan, and you can see there are dysplastic vessels inside the tumor, if you want to treat the tumor, this cancer lesion using heat, for example, with radiofrequency ablation, or using cold with cryoablation, the problem of this major blood flow inside the tumor is that it's going to dissipate the heat or the cold, and it's going to mitigate and impede the efficiency of your treatment. So the goal here of embolization is to completely devascularize the tumor, which will improve the efficacy of the treatment. At least this is the theory. We do not have major evidences about that, but when you have very highly vascular tumors, big tumors with dysplastic vessel inside, it's probably better to embolize them before going for ablation to have a better outcome. And I'm going to show you more examples. So this is just how it looks like, and to show you and emphasize a lot also on the quality of treatment. So this is the room we work in. So we work in, that's an angio-CT, combination of a CT scan and of a C-arm, beautiful Canon machine, of course. And the goal here is to have access to all modalities for one single session treatment. So here for that metastasis, we went for fluoroscopically guided embolization of this highly vascular mass. And you can see here we embolize with glue. So here was a liquid embolic. And then as soon as you have done it, you can change the setting of the room. This is a short video to show you we switch from a vascular approach to a percutaneous approach. So it's a two-step procedure, but which is done in a single general anesthesia. And here we go for the ablation. This was done with cryoablation. So you are here the patient in the CT gantry, different cryoprobes here. And here you can see, of course, it's mandatory to have high quality image guidance. Here is the CT scan on the axial view with the probes, coronal view with the different probes showing you good repartition within the tumor and proper coverage of the tumor with the ice ball. And because we just embolized that tumor, we do not suffer from the sink effect. So we do not have the high vascularization, which is going to heat a lot our ice. And so the ice is going to be more toxic, more necrotic for that cancer. So as you have understand, embolization, when we talk purely about percutaneous treatment, is most of the time not used as a standalone method, but usually with as a combination, as an add-on to prior to ablation to optimize the treatment. And I'm going to show you at the end one example of a very large ablation using the combination of both. So ablation now. Thermal ablation is an important tool when we have to treat bone tumors. Those are the different techniques we have. We have chemical ablation, which was the first described in the literature using ethanol, but not really reliable. We have thermal ablation, and here different techniques, radiofrequency ablation with also different types of radiofrequency ablation, microwave, laser, HIFU. This is heat-based modalities. We also have cryoablation, which is going to ablate tumors using ice. And finally, non-thermal, non-chemical ablation. You may have heard about that, irreversible electroporation, and also a new kid on the block for bone tumors treatment, electrochemotherapy. So right now, I will focus mostly on the most, not most advanced, but the techniques we may use the most for the treatment of bone tumors, which are cryoablation, bipolar radiofrequency ablation, and electrochemotherapy. So you have an overview of the different techniques which are most of the time used in 2022 for the treatment of bone tumors. Microwave may also be used, but currently there is no specific algorithm, and so we use it cautiously for the treatment of bone. Just a very quick reminder about history. So treating tumors started with liver, then lung, kidney, and finally bone was probably the last organ that was targeted using this treatment. And at the beginning was mostly done using monopolar radiofrequency ablation, so with the same devices as we use for liver or kidney treatments. And here is an example. But the point is that with this technique, we had to deal with purely osteolytic tumors, which were far away from vulnerable organs, such as nerves, which are usually close when you have to treat bone tumors. And so it was, of course, an interesting tool, but not perfect tools. And now I'm going to show you that we have access to better technologies. So cryoablation, it may look like a new kid on the block, but it isn't. The first series about the efficacy of cryoablation to treat bone tumors were reported in the 70s in the literature. And here you see how it was usually performed. It was an open surgical access using liquid nitrogen to freeze the tumor directly within the lesion. Of course, if you look at the devices that were used, it was quite large and it required, of course, a very invasive approach. With the arrival of argon-based cryoablation, the companies were able to make the needle and the probe thinner. So 70 gauge, it's really thin. And this is how the ice ball looks like outside. But the beauty of cryoablation is that you see the ice ball inside the patient using CT scan. Here is an example on the treatment of a bone metastasis located on the rib. You can see different cryoprobes positioned around the tumor here, and we beautifully see the extension of the ice ball around that lesion. So what is good with cryo is that we see immediately if we cover the tumor, we see if we have the safety margin, but also when it comes to difficult locations such as this metastasis located at the head of the rib close to the spine, we can see the relation between the tumor, the ice ball, but also in that case, the spinal cord. So look on the coronal view, how nicely we can depict our ablation area, which is mandatory in such a difficult location. So I would personally never go here with RFA or microwave without any adjunctive techniques. While cryo, as you can see what you're ablating, this is definitely a major improvement for us. Second advantage of cryo, you are able to activate simultaneously several applicators, which allows you to ablate large to very large ablation up to 10, even 15 centimeter mass. Here is an example of metastasis located on that rib, posterior arch of the rib, invading both the lung and also the muscle behind. And you can see here the huge ice ball, which was achieved using 6 cryoprobes. We have been treating a 8 centimeter area, so not complete coverage. Here was a palliative treatment. The goal is to decrease the pain of the patient. And with cryo for big tumors, we are now able to achieve such a result. A final advantage is the treatment of osteoblastic metastasis, which may happen in up to 10 to 15% of the cases. Painful osteoblastic metastases are usually not accessible to radiofrequency ablation because a blastic bone is going to increase the impedance. There's no good diffusion of the electrical current, while with cryo, as you can see on this sternal metastasis, which was approached with the caudocoronal access, you can see that the ice ball extends completely beyond the limits of the bone without any problem. So whenever you have to treat a patient with prostate or breast cancer and blastic metastasis, cryoablation is really a nice option. Another tool that I want to talk to you about is bipolar radiofrequency ablation, which is mostly indicated for spine. So spine is a challenging location. As you know, first of all, the vertebral body is usually not round, so it's not like a typical round tumor. Second, it's very difficult to access the posterior part of the vertebral body as we're going to approach it using a transpedicular access. And finally, of course, we have the neural elements which are posterior to that vertebral body, and we don't have to ablate this, of course. So bipolar RFA are new tools. You have different companies providing either straight electrodes or steerable electrodes, but the goal is always the same. With bipolar RFA, you have 2 electrodes on the needle, which means that the current is going to circulate only between the tip and the distal electrode of the needle, which means that you are able to control very precisely within the spine your ablation size. And those are 2 MRIs performed after treatment. You can see here the nice ablation, abuting the posterior wall, same thing here. And because of the good control, we tend to decrease as much as possible the risk of spinal cord or coda echina injury related to thermal injury. Of course, the development of thermoprotective techniques has been a key for the evolution of thermal ablation treatment. We have different tools, hydrodissection using fluid, carbodissection using CO2. We can stimulate the nerves. We can use evoke potential to use stimulation from the brain to the nerves and making sure we're not injuring the spinal cord. And here is an example on the right side of how we can use this. For example, if you are ablating a tumor within the vertebral body, you can position a needle between the dura and the vertebral body, inject fluid to push away the dura, and this will decrease the risk of thermal injury while ablating. You can also add a thermometer to make sure that the rate of injection is perfectly adapted to the treatment itself. Just a short example of a spinal ablation using bipolar radiofrequency ablation. So this is a CT scan, CBCT acquisition showing the position of the probe. And as you may see, this little structure here is a thermometer that was inserted through transforaminal access on the midline, on the mid-height of the vertebral body, which means that when we are ablating, we're able to monitor the temperature. And you can add dissection with it. That is fluid with contrast to show the repartition. You see the epidural diffusion of the fluid pushing the dura, which means that when we are ablating, we not only have access to the temperature, but we also have an added safety margins relative to the nerves here, which means we can ablate very aggressively, including close to the posterior vertebral body wall, without fearing of suffering from thermal injury. A final word about electrochemotherapy, which is quite not a new technique. It has been reported for years for dermatologic treatments, but it has recently been proposed for the treatment of bone metastasis. The goal is to insert different electrodes around the needle, like for thermal ablation, but we're not going to apply heat or cold, we're going to apply electricity. So what you're going to do is use a high voltage in between two electrodes, and this is going to open the pores of the cell of the membrane of the different cells. And depending on the intensity of the electricity, you are going to create either reversible electroporation, so reversible opening of the membrane cells, or irreversible electroporation. The cells are going to die by apoptosis. And if you combine the different needles that you have put in, you can, of course, open the pores in different locations and cover a tumor which is ranging between 2 to several centimeters. So there are different options that can be used. As I said, irreversible electroporation, which is mostly used for liver, but not that much for bone tumors, and reversible electroporation. And this is what we're going to use for electrochemotherapy. So the goal here is to apply a reversible electroporation, and then usually 8 to 10 minutes after the treatment, the electroporation, we're going to inject chemotherapy intravenously, usually bleomycin. And this is going to enter the cells which have been previously treated with electroporations, only in the area that you are treating, and the tumor is going to be treated by chemotherapy. So it's not a thermal effect, and because of that, you can reduce the risk of thermal damage. So what is the indication for such a treatment? And it's probably going to increase a lot. Patients suffering from spinal tumors, such as this one, who had benefited already from radiation therapy, who are usually not really candidates for surgery, then you can offer such a treatment. So you can see we position several needles. We try to be as parallel as possible to have the electrical current as homogeneous as possible. Then you apply the electricity, you deliver the intravenous chemotherapy. And this is the control 1 month after. You can see a slight decrease in terms of mass effect of the lesion, but also quite a nice necrosis of the lesion without any neural deficit, despite the fact that the Coda echina was really in between the two electrodes. So for lesions which are completely inaccessible through thermal ablation, this may be a major progress for the patient. So what about the indication of ablation? Pain palliation, you can treat patients to decrease their pain related to bone cancer. It has been shown to be effective either before, if the patient had radiation before, or even in radiation naive patient, and usually you're not dependent on histology. So it basically works on any kind of tumors, and it works very quickly, starting the effect after 2-3 days of the treatment, and usually you have an effect which is significant after only 1 week, while with radiation, we know it's between 2 weeks and a month. And an increasing field of indication is local tumor control with this technology. because we can not only treat the pain related to bone metastasis, but we can also ablate completely a tumor, such as the osteoidostoma case or the spinal cervical case shown by Professor Bloom in the previous presentation. So indication for ablation: benign tumors where you want to ablate the lesion. This is a case of an osteoblastoma that was ablated with cryo, and you can see here proper coverage of the tumor. So you choose that technology over surgery, and osteoidostoma, osteoblastoma, chondroblastoma are typical indications of ablation. And we can also apply ablation for the palliation of painful bone metastasis to reduce the skeletal related events, because as we're going to control the tumor, it is not going to increase in size and to cause any issue. And finally, for specific disease, patient with a very limited number of metastases, oligometastatic status, we can also treat completely that patient. And this is an alternative to surgery, which is usually not performed, and also an alternative to stereotactic body radiation therapy. And you have an example here of the kind of necrosis you can achieve using cryo. I'm going to skip this because of time. A final word about bone consolidation, another major topic of application of our treatment. So cementoplasty, very basic technique. You insert a needle, as shown here, and then you inject the acrylic bone cement, which is usually PMMA under fluoroscopic and or CT guidance. So cementoplasty has an excellent resistance to compression, as shown here. So it's a perfect indication for the vertebral body, or the acetabulum, or sometimes the epiphysis of long bone. Different example here, a vertebral body consolidation using PMMA to prevent further collapse of the vertebral body. Here, a treatment to treat that impending fracture of the acetabulum. So here, PMMA is perfectly indicated. The problem of cementoplasty is that you cannot really fix a lesion. It is not going to fix a fracture, for example, as shown on that rib fracture. So if you cement this, the patient may be relieved from his pain, at least transiently, but anyway, it is not going to consolidate this. So we now have not a new tool, because it has been used for a long time by surgeons, but we can take advantage of the very high quality of image guidance in interventional radiology and use those cannulated screws. So here we need very few material, a wire, and then a cannulated screw and a cannulated screwdriver. So the principle is very easy. You advance the wire with image guidance, and then over the wire, as shown here, those wires are in position. You insert the screw over the wire, and you advance it using fluoroscopy for a final position. So it is done without surgical opening. And the typical indications are pelvic pathological fracture, as shown here. This patient has a melanoma. There's a displaced fracture of the iliac bone, which is painful. You can imagine this is not going to be treated with surgery. And here we can fix the problem using 2 screws, which were inserted with the technique I just have shown. Now, in most of the cases, we're going to combine screw and cement, because in cancer patients, either related to the cancer disease or the underlying osteoporosis, it's better to increase the anchorage of the screw with cement, and also to increase the resistance of the weight-bearing area with cementoplasty. And here is a typical case of a myeloma, large lytic lesion, pathological fracture. So the fracture was fixed with 2 screws, and then we're injecting cement to reinforce the roof of this acetabulum, and also cement to increase the anchorage of the screw within the cancellous bone, which may be pathologic because of the myeloma. So major indication for bone consolidation are the use of cementoplasty for the stabilization of impending fracture or fractures of the vertebral body, and the combination of screw fixation and cementoplasty for the stabilization of fractures of the pelvic bone. But there are other places that may benefit of such a treatment. Here is a sternal fracture. Cement is not going to fix the problem. The patient has myeloma, so we fixed it with 2 screws reinforced by cement to optimize the outcome for the patient. And very briefly, you can combine the technique. Here is an example of a very large hypervascular metastasis from HCC. So as I said before, here you can combine embolization to decrease the vascularization. And as soon as you have done it, so single session treatment, if you have an angio-CT, you can go with cryoablation. And here is the necrosis you can achieve at 1 month's follow-up. So very large tumors can be treated. You can also combine consolidation and ablation. That's an aneurysmal bone cyst, benign tumors. The bony lesion was treated with using cementoplasty, and the extra osseous component was treated with cryoablation, as you can see here. That's the MRI prior to treatment. That's the MRI 2 years after. So complete disappearance of the tumor. You can treat and achieve complete treatment in benign tumors, even in most complex cases such as aneurysmal bone cyst. And a final example, just to show you everything in one case, a large lytic metastasis from breast cancer located at the ischiatic part of the pelvic bone. Quite a complex treatment, as you can see on fluoroscopy. That's a video from the CT scan. So different cryoprobes were inserted. And this also illustrates you the hydrodissection. So what you see here is the ice ball, and what you see with the contrast here is fluid with a bit of contrast. And you see how nicely we can depict the sciatic nerve, making sure the ice ball here is not touching the sciatic nerve in any part of the volume of the lesion. And by doing so, you can achieve complete treatment. That's a PET-CT 1.5 years after. And what you see in the mid is consolidation, because the patient suffered from a post-ablation fracture, and we fixed it with a screw reinforced by cement. So you can also fix the complication that you may have induced. And then, of course, it's mandatory to know exactly when to propose consolidation in addition to ablation. So coming to a conclusion, I hope you are convinced that interventional radiology is a key treatment, not only for benign bone tumors, but also more and more for the palliation of painful bone metastasis, and also for the destruction of bone mets in selected cases. And this is most likely to grow because with the advancement of systematic treatment, mostly immunotherapy, we see more and more of these oligometastatic or oligoprogressive cases. Thank you very much for the attention.
Thank you, Julien, for this overview and really extensive cases we have seen here. And we have some questions from the Q&A, and I would like to start the discussion in the way that we start with Professor Blum. And I have looked at the questions, and you have also already answered some of them, but I think we should discuss some of them in details. You mentioned that there are different techniques, and you mentioned not only subtraction imaging, you mentioned perfusion, you mentioned open rib, metal artifact reduction, and also ultra high resolution. And looking at subtraction, there was a question on how do you think this relates to information we gain from spectral imaging? So you showed a case from 2009 when you started. Is spectral imaging now more in your practice, and how do you think can it advance the differentiation of tumors?
Well, we don't have access to the last version of Canon CT scan, and especially on the Prism, which probably yields better results for spectral CT. But we have been trying for a long time this technique with different options. And we were rather disappointed about the results compared to what we get with subtraction technique. The contrast, the amount of contrast of what we get between pre and post-injected images is so high that I don't think that the spectral CT so far is able to compete. Maybe it will be the case with photon counting CT, but right now we have results are so impressive and so with high specificity and high sensitivity in the detection of lesions, that I think that we will not switch and go back to spectral CT.
I see. And there was the point on, and you mentioned also ultra high resolution. It seemed to me a little bit like you said, well, this is really changing things. We are looking differently now on some of the tumors. And in what respect does that change your confidence in diagnosis? Because there are these criteria, like you said, the typical appearance of fibrous dysplasia, but looking at cases which are not typical, does this help you in differentiating it, or does it convince you more? Could you elaborate a little bit on that?
I think it's too early to determine what is the diagnostic impact of ultra high resolution. But I think that in many cases, it improves our confidence in the diagnosis of some lesions, because you have some time to be confident enough to say that's a benign lesion, no biopsy is necessary, no follow-up is necessary, or on the contrary, to prove that it is a lesion which can be treated with thermoablation, like osteoblastoma or some chondroblastoma. Or in some cases, of course, you need you need a biopsy, a histologic confirmation to reach a diagnosis. Nevertheless, it improves our confidence, and also I think we will come up with a new description of bone tumors in a few years. We have to improve. We have to understand what we are looking at. And as we are getting closer to histopathological findings, I think that we will gain in efficiency. And typically, the ground glass appearance is the example of what we see with imaging techniques, but it is just due to a lack of spatial resolution. With a normal CT scan, if you compare sometimes the standard algorithm with a high resolution algorithm, just with a normal CT scan, you will see a huge difference between the aspect of the bone lesion. And that shows you that we have to still improve the spatial resolution to gain in diagnostic efficiency. So we have to learn with this new technique, and with photon counting technique, this new technique will also be present.
So this opens a new window, actually.
Absolutely.
In this week. I would like to switch now to the talk of Julien, and you showed not only that different techniques are able to achieve different goals. You mentioned embolization as one goal, to either devascularize the tumor and to treat it in the same session or a subsequent session by surgery or even by ablative means. And there was a general question from the audience who's probably not so familiar with how you do it. You showed coils and you showed particles. Is that the agents you use mostly, or are there other agents which are specifically used in these cases? What's the question in the talk here?
Okay, that's a good question. So, so to be basic, we have different embolic agents. You may have coiling particles, which are mostly used to devascularize the tumor itself, while core is going to stop the inflow from the feeders. You may also use embolic agents like glue, for example, but this is a bit more tricky to handle, so you have to be very trained. And the final embolic agent which may be used is a temporary embolic agent such as gelitaspam. So it really depends upon the indication. So for example, if we have to ablate a tumor and treat it right away with ablation, usually what we would go for is either use particles or a temporary agent, as we know we're ablating it immediately. But the general practice, and probably you would agree with me, is that for bone tumors, if you have to treat it prior to surgery or ablation, we would use particles. And most of the time, we would close the feeders with coils after feeding the tumors with particles. I cannot hear you, Thomas. I think you're muted.
Thank you. You mentioned that ablation is a second part that can be used, or a second technique that can be used. And ablation, as you said, is well known, has been long known for liver tumors and lung tumors, and bone is a little bit lacking behind, but I think we are there now. But when you consider imaging in this respect, how important is for you the CT imaging and planning, and do you plan things in advance, and how do you do this? Because it looks complex and it cannot be done on the spot. Obviously, you have to have a plan here. Could you just elaborate a little bit on how you deal with such a case and how you plan it?
Of course, having a plan is key. It's like not only for IR, it's general advice in life, especially for interventional radiology, because you have to know in advance which is the size of the tumor. So basically, how much needles you are going to use? Would you need embolization before it? Are you going to require consolidation after the treatment? So is it a weight-bearing area? Is there any vulnerable structure around? And when we talk about bones, nerves are usually in the way. And if there are any nerve, how are you going to protect it? So of course, planning is key. And personally, I usually do it in advance and go usually the day before again through the images, making sure I have a perfect plan. And this is half of the success of the procedure. And of course, the quality of image guidance is key. And to my point of view, when we treat bone tumors, CT scan is mandatory. You know that you have CBCT where you can have a 3D acquisition and CT-like imaging, but it's CT-like. It's not as good as CT. So you definitely need a CT scan to have this precision. And of course, what best than a Canon CT scan if you want to achieve such a result?
True. So coming from that part and planning and advancing that area, and you showed the advantages of cryoablation by visibility of the ice ball, by controlling how you get near critical structures. And this seems to work very nice. And the question to me is now, and I think that it's something the audience also interests in historically, most of these cases were treated either by surgery or by radiation therapy. So how does these ablation and consolidation fits in here? How do you convince your colleagues that they not choose radiation therapy to treat this? What are the arguments at this point?
So there may be several arguments, and I skipped a very brief paper over the presentation that I may discuss now. So first argument is that, for example, if you have a patient who has a progressive tumor, you can treat it, but also biopsy it in the same session. So you can do the diagnostic, or for example, a reevaluation of the mutation and treat the problem right away. That's the first advantage. Second advantage, the time to response for the patient is faster with ablation than with radiation. So if you have a patient who is in pain, if you can provide the treatment quite quickly, the patient is going to be alleviated much quicker than with radiation. And finally, in patients suffering from lesions which may fracture or which are actually fractured, you can also do in the same session destruction of the tumor and consolidation of the lesion. So those are the different advantages of using the treatment. And you can also apply ablation after failed radiation, which is also something that you have to keep in mind. And a final point is that you can combine the treatment. So there are not only very high level evidences, but literature is suggestive of the fact that a combination of ablation plus radiation may improve the outcome for the patient, especially for the patient who have a long life expectancy. Maybe this is the place to combine the different treatments. So you are going to treat the treatment with ablation and then add radiation.
I see. And looking a little bit more into the technical or the decision making, when we look at ablation, and are there cases where you say, well, doing cryoablation, so dealing with cold, is better than dealing with heat? We have seen these examples which are near close critical structures, but is that also true for the opposite, where you think that ablation of, let's say, benign tumors or second-degree bone tumors should be done differently with respect to the technique, either heat or cold? Is there any differentiation, or do you think cryo is the best in every case?
No, it's not the best in every case. This is why I mentioned also bipolar RFA. So I'm just going to detail my practice. Of course, it may differ from centers to centers, but if you have an osteolytic metastasis which is located inside the vertebral body, so in the spine, I would use bipolar RFA, because in that location, you are not really seeing the ice ball during the treatment. And bipolar RFA is usually much more controllable and reliable. So for spine metastasis, if they are osteolytic, I would use bipolar RFA. Then if you have an osteoblastic tumor, or for any pelvic bone tumors or any tumors extending into the soft tissue, I would go for cryo. And if there is a nerve inside, then we start to think about electrochemotherapy. So for example, if you have a spinal mass with epidural extension or a huge pelvic mass invading the sciatic nerve, for example, or all around the sciatic nerve, this is the place where electrochemotherapy may make sense. We need more data about that. So we started this technique over 6 months ago, and we need to see more how it works and if we can achieve good treatment.
Then one last question on the procedure itself. You didn't mention it specifically, I think, but general anesthesia is, at least in the last cases you showed, the way to go, I guess.
Yeah, we do all ablation with general anesthesia, except very specific cases. For example, if you have a very small lesion where you may want to have the patient under conscious sedation to have his feedback. But now, as we have access to electrostimulation, neurophysiological monitoring, access to temperature, we do everything under general anesthesia because usually it's painful when you ablate. Most of these patients are either young, so quite prone to stress. You're not going to treat them under local anesthesia, or cancer patients, who unfortunately suffered a lot during the course of their disease, and they don't want to see anything, hear anything. And you work better with the general anesthesia because you do more aggressive treatment. You do better needle positioning. There is no question that general anesthesia is improving the technical part of the procedure, and usually, I believe, the outcome.
Then maybe one last question on both of you. When we look at the advancements that are made, not only diagnostically, but also therapeutically, what is the best way to transmit this to your colleagues? How do you do it in Nancy? How do you do it in Strasbourg to really convince people that these images you have are of importance, that the treatment is safe? How is that done at your places? Maybe Professor Blum, you can answer this. Is it a regular tumor board meeting where you show up, or because not everything can be written down in the the report, I think.
You're right, but during staff meetings and during multidisciplinary team meetings, we share our experience with our colleagues, surgeons, and young residents also participate to these staff meetings, and they can see the importance of be trusted by our colleagues, by surgeons, and the way we also share the information with pathologists is very important. And they're very rapidly convinced by the interest of improving the image quality. Really.
Julia?
Yes, I think from the interventional side, I would say patient outcome. So if you can propose a treatment to the patient and the oncologist, for example, because you have a high quality imaging, then they are most likely convinced that your tool is excellent. Whatever this tool is, they would trust you.
Okay. So I'd like to hand over now and close this session here and hand over to Jackie Hislop to give the final words here.
Thank you, Professor Conquet. That brings us to the end of day 4. As Professor said, I'd like to again thank our speakers and moderators, Professor Conquet, Professor Garnon, and of course, Professor Blum. Outstanding presentations, and thank you all for the genuinely interesting discussion, both in this panel and online, with Professor Blum answering several questions. And we hope to see you all again tomorrow as we finish up our MSK days with a discussion on osteoporosis, arthritis, and sarcopenia. So thank you all for joining this evening, and we hope to see you again tomorrow. Thank you very much.